This is to mark the release of Risking Life and Limb, a review of acute limb ischemia. So we're going to hear from Aaron Prawani to start with, because he's going to tell us why the study was proposed. Then actually David Wood, who's one of the authors, and Simon McPherson, who's the other author but's currently stuck on a train, so may join us at some point, going to present the sort of main highlights of the report. Then we're going to hear from Rachel Bell from GIRF to tell us what this means and how this aligns with GIRF data. And then Ian Chetter at the end is going to tell us what the Vascular Society are going to do with the report, so what this means for patients. So with no further ado, I'm going to hand over to Aaron.
Thanks very much, Marissa. So good afternoon all. Welcome to this webinar. My job was to introduce it and to tell you why we put this study in. But I'm going to begin by actually thanking several people. I'd like to thank Marissa. Marissa is the chief exec of the of NCEPOD, and it was a tremendous amount of support from Marissa and the team that allowed us to get over the line, get this project approved. Hannah's done a tremendous amount of work, Leah, the background, and of course, David and Simon, who are the authors of this report. In addition, the first application to NCEPOD was put in by Chris Imray when he was the chair of the research committee, and it went through several iterations until it came to me when I was an audit chair to put it through. And so this was combined effort from several people, and I have to acknowledge the role of Chris, John Boyle, who was my predecessor, as you know, on the audit committee, Sandeep Nandra, who helped a lot, and others who supported us. Every organization came up with support. The reason we put this in is because the NVR does not capture data on acute limb ischemia. What the NVR captures is limited by the framework that HQIP impose upon the NVR, so we can capture, as you know, the chronic conditions around the lower limb aneurysms, carotids, amputations, etc. That was one reason. Secondly, there's very little data available in the UK around acute limb ischemia, and it becomes very difficult to separate what acute limb ischemia is from CLTI on account of essentially no codes for acute limb ischemia on HES. There was the European Society guidelines more recently around ALI, and we'd never had guidelines in the UK. You know, we work in hub and spoke models, and there are delays to transfer. We've demonstrated this with the CLTI work, but we did need to demonstrate this with the acute limb ischemia work. And some of the findings of this study actually show that. So, we know, this is not surprising. The depth of it, or the extent of it, certainly is. And as we know, essentially, we're talking about 6 hours to save a limb. So these patients require to be seen and treated early. The other reason why we approached NCEPOD is because they have a long history, a very successful history of developing and delivering audit projects, and the infrastructure they have is brilliant. We, as a vascular community, benefited hugely from the 2014 NCEPOD amputation study, and I was an advisor on that report, coming into the NCEPOD offices, looking through the case notes, and it is fair to say that that particular NCEPOD 2014 report changed amputation practice throughout the country. And I was hoping, and the hope is that this particular report changes the practice here. So I'm going to stop there and hand over to David and Simon, if he's here, to talk to us about the report.
So thanks very much, Aaron, for that introduction as to why the study was needed and the background to where we got to doing the study and the report, which was published a few weeks ago. I'm just going to briefly cover the methodology. Aaron mentioned a little bit about some of the difficulties there about identifying patients with acute limb ischemia, because currently there is no specific ICD-10 code, which is the code we usually use to identify patients. And so we were very grateful for centres to put in a local study contact who would screen potential cases where we use a combination of ICD-10 codes and an emergency admission to exclude non-acute limb ischemia cases to try and identify the population we wanted to review. And we looked at patients admitted 18 or over who were admitted to hospital in January to March 2023 with acute limb ischemia. We identified 488 patients within that. And then there was a number of different questionnaires. Those people who've been involved will know that there is a questionnaire sent to the clinician responsible for looking after that patient. We also get sets of notes, as Aaron alluded to, when he worked on the amputation study, which we then reviewed in the NCEPOD offices. And we're grateful for all the reviewers who gave up their time to undertake those reviews. We had questionnaires to GPs and primary care facilities. We also had some questionnaire and surveys for ambulance trusts involved in the transfer. And then we had organisational questionnaires, which look at not the actual care, but the processes around how care is provided, both from vascular hub hospitals and spoke hospitals as well. As Aaron mentioned, there is a pathway that these patients are looking after, and there are a number of steps in that where potential difficulties in terms of delays and also the care provided can occur. And that initially starts with the patient becoming aware they may have acute limb ischemia. They may then present to primary care, they may go to a spoke hospital emergency department, or they may go directly to a vascular hub if that happens to be their local emergency department, or they've had contact before and know that they should be going there. And then there are transfers between those institutions where there are potential issues in recognition of acute limb ischemia and also in terms of transfer between them. I've mentioned currently vascular services are provided on a hub and spoke model, and these are a couple of figures which are available in the report showing where the vascular hub centres are and the spoke hospitals which then transfer patients to them on the left-hand side. On the right-hand side is a graphical representation of an average 60-minute drive time. And you'll see there are certain areas of the country where there are more than an hour to get from a spoke hospital or from a primary care institution to a vascular hub. And obviously the critical bit there is around the time in which you have to save a limb when someone presents with acute limb ischemia. So I'm going to now move on because unfortunately I mentioned Simon wasn't able to get here at the start to kind of go through what we found in the study. And I'm really going to go through the key findings, and these will be used to form the recommendations and the outputs from the report. So the first thing really is that the main starting point for someone getting care for acute limb ischemia is that someone recognises that they have acute limb ischemia. And that may be challenging because a lot of these patients may have an underlying chronic limb ischemia, and therefore worsening their symptoms they may not recognise as acute limb ischemia. And also patients who've never had acute limb ischemia may not realise the severity and the significance of symptoms they develop. And it's important, looking here at some of the data which is in the report, but over 50% of patients presented to hospital more than 24 hours after the onset of symptoms. And as Aaron mentioned, there is the golden 6 hours to try and save a limb. And so if patients are presenting late, the opportunity to potentially intervene to save a limb is significantly reduced from that point of view. There's also a lack of recognition in primary care and also within spoke and even within hub hospitals with patients presenting potentially to an emergency department with acute limb ischemia. And particularly this is very more significant for patients who have brothers of 2B, where definitive intervention within 6 hours potentially can prevent loss of a limb from that point of view. So the recommendation around this was about improving patient and public awareness about the issue of acute limb ischemia, how to recognise the potential symptoms that they may develop as a result of developing acute limb ischemia, and what they should do and how they should then present to services from that point of view. The next thing is that patients do present to a variety of different facilities. They may, as in the pathway at the bottom, they may present to primary care, they may present to a local emergency department in a spoke hospital, or they may present directly to a vascular centre, either because, as I mentioned, that may be their local emergency department, or it may be because they've had previous contact with them before. There are obviously, every time a patient presents to a non-vascular hub, there will need to be a transfer or a recognition initially that the patient has acute limb ischemia, a discussion potentially between that institution and the vascular hub about transfer, and then there will need to be a transfer by ambulance from either primary care or from the spoke hospital to the vascular hub. And so therefore, there are delays that can occur within that. And also there are issues around how communication happens between institutions. The Rutherford score is a way of recognizing the severity of acute limb ischemia. And often individuals may discuss the symptoms in a way with a specialist centre that is following the Rutherford scoring, but often that is not clearly documented within the notes, and therefore it's difficult to know whether the severity was truly recognised by the referring hospital. In addition, in the blue line at the bottom, there's about the ambulance transfer, and only one of the 4 ambulance trusts that provided information to us had a bypass protocol for taking someone with a suspected acute limb ischemia directly to a vascular hub, removing the intermediate stage of going via a spoke hospital from that point of view. And so this recommendation from this was around how we can improve the pathway to patients who are presenting, cut out delays, and try and get more patients directly to a vascular hub when there is a high degree of suspicion of acute limb ischemia, and particularly in those individuals who may have Rutherford 2B classification. As mentioned, the way vascular care, along with other very specialist services, is a hub and spoke model. And so obviously there needs to be some work done to improve the way the vascular network interacts with the spoke hospitals and how information is provided to the spoke hospital in terms of both patient notes, imaging, and so that there isn't duplication of imaging when someone gets to a hub hospital, and also that there isn't delays by individuals having imaging done, which doesn't necessarily need to be done in the spoke hospital and can put an issue in terms of delay, in terms of transfer between them. We also need to improve how we share records. Obviously, many trusts are now moving towards more electronic patient records, which does allow more free communication between trusts. But obviously, that does rely on the issue potentially of whether they have compatible systems which allow transfer of both medical records and also imaging to enable things to be more readily shared from that point of view. As mentioned in the initial thing by Aaron, is around trying to improve the care through development of a national guideline, which would cover what investigations need to be done, how to improve the transfer of patients from primary care, the recognition of potential acute limb ischemia, how to classify patients using the Rutherford scoring category, making clinicians aware that not all of the CIP-Ps, which people often will refer to, have to be present in individuals who have acute limb ischemia, and including those who may have potentially significant acute limb ischemia, and also about investigations, management, and how that can be best delivered going forwards. And the final thing was around, as mentioned, we had difficulty in identifying patients because currently there is no ICD-10 code for acute limb ischemia. ICD-10 has been developed. It's currently in pilot phase in different countries around the world, and potentially will be adopted in the United Kingdom. And that does have a code for acute limb ischemia, which will allow more capture of these patients. As I mentioned, the vascular registry doesn't currently collect information on acute limb ischemia, and the ability to look at outcomes, look at how processes can be adapted to improve care, look at problems in the delivery of care, does require ongoing prospective collection of data from both spoke and hub hospitals to look at how things can be improved going forwards. And the recommendation here was really around developing a national data collection system for acute limb ischemia presentations to enable better care to be delivered and further auditing and improvement of that care going forwards. In addition, that will be also facilitated through ICD-11, but there's currently no time frame for when that will be in place. So I'm now going to hand over to Rachel to update us.
Thank you, David. So I think I was asked as a GIRF lead to comment on this the results of the study, but also to say where GIRFT might be able to help with some of the recommendations. So for those of you on the call who are unaware of what GIRFT stands for Getting It Right First Time. There's a national clinical leads for most specialties, and myself and John Boyle are the two GIRFT leads for vascular surgery. We're in the process of doing face-to-face visits with all the vascular hub sites around the country, and so we have a very privileged and unique view because we get to talk to everybody about their local services and where their local tricky challenges are, I would say. My reflections on the study overall is that I wasn't really surprised by the results. I do think that there is a failure to recognise acute limb ischemia, and both from a patient perspective, but also from a clinician perspective. And so some public health awareness and, making people educated, a bit like the FAST campaign for stroke, which was very successful. Something similar for acute limb ischemia, I think, would be incredibly helpful. Also, I have run a network in the past and I've visited many of your networks. I know how difficult it is to transfer patients in a timely manner between hospitals with all the bed pressures that we suffer. And so I think that really clear pathways between organisations and help from the local ambulance service is essential, because a bit like when we set up the ruptured aneurysm pathways, if you identify these patients or the ambulance crew suspect acute limb ischemia, there are, like with aneurysms, you can direct them straight to the hub site and without taking them to a spoke site, and that would reduce the time to treatment significantly and possibly have an improvement in the outcomes of patients who need surgery for acute limb ischemia. So I think two of the recommendations particularly align with some of GIRFT's aims. One is organisation of the vascular networks around the country. So we are currently, vascular has some informal networks, but we are not like renal or cardiac or cardiology that have formalized transformational networks, which mean they have funding for people to manage those networks and to look at service improvement projects and to run those projects and to audit, audits like this, I suppose. Ours are informal, we have no funding, but John and I we have an ambition to push for funded transformational vascular networks, and subjects like acute limb ischemia would be absolutely prime for improvement in amongst the network work. I think it would really help developing better pathways of care for ALI between the arterial and non-arterial sites. And as GIRFT leads going around the country, we could be used to interrogate various units. We use the interrogation as a gentle word. It's not, we're very nice to you when we come to your units and we talk as your advocates, but it would be nice to hear how you're doing developing those pathways and to make sure that all the safety measures are in place. I do think that would also help with conversations with national ambulance services about taking patients to the correct site, as I said before. And then we've seen a real problem nationally with the ability to repatriate patients from arterial hub sites back to hospitals closer to their home so that they can rehabilitate closer to their family, and it's easier to sort out social services. There are a small number of networks, I would say, that have sorted out the repatriation problem around the country, but they are definitely in the minority and it's a real struggle for people. But having those formalized networks and having some senior leadership around repatriation policies between hospitals in your region might be something that we could try and help with. And then I'm sure that Ian is going to talk about this as well, but I think we could also support recommendation 5, which is around the data capture. So all of your GIRFT visits and all of our recommendations from GIRFT are based on data that we get from Model Hospital, which is HES data. which is data that you put in yourselves from coding patients' episodes. And so, as people have been saying, it's not easy to identify these acute limb ischemia patients, but I think Arun Fawani has done some amazing work with acute dissection that also we had problems identifying medically treated type B dissections. If we could do something similar for ALI, I think we might be able to have a data set that we could keep an eye on. The MVR is a different way of entering data because the clinicians input that data, and so whether it's possible to change the MVR to add some additional fields to capture ALI patients, but I would very much hope that would be possible. And then with data, that would allow us to benchmark you as networks as to how you're doing around your ALI performance, and also then look at where the problems are and try and help you solve them. I think that's all I've got to say from a GIRFT point of view. I don't know who's next on the agenda because I can't see the agenda. I think it's Ian Chetter, actually.
Thank you very much, Rachel. And it's really good to see that the recommendations coming out from our report are very similar in some respects to some of the work you want to do through GIRFT. And that helps to sort of support the work you want to do in the fact that we found the data to support that. So it's really useful from that and highlighting where the two organisations and processes will help align. So we're going to now hand over to Ian, who's going to talk about what the report means for patients and how the Vascular Society of Great Britain and Ireland is going to use the report going forward.
Thanks for the invite. I think the first thing I want to say is congratulations. This is the best data set I've ever seen on acute limb ischemia, which is often at the bottom of vascular surgery priorities. And the data around it is consistently pretty poor. So congratulations, it's a fantastic data set, and it's the first real hard evidence that that tells us how we're doing in the management of these patients. Okay, I think the first thing that comes out of the report is that we must raise awareness of acute limb ischemia, both with patients in primary and community care and in emergency departments. And you guys have made some very sensible suggestions about how we might go about raising that awareness. So it's about education. Educating patients is challenging, and the pathway and the methods to do that are very difficult. Also, getting into primary care and community is also challenging. And we found a similar problem with CLTI. We've had a quality improvement program ongoing, and these problems have been raised with CLTI prior. The reason I've highlighted the two suggestions that I have is these seem probably the lowest hanging fruit, the easiest thing we could do. We could have posters in GP practices. We could have infographics on websites, etc. That would be pretty straightforward to do, and something we've done with claudication, and something we've done with the Ring project with the SVN for critical ischemia. And then the second low-hanging fruit is the template to standardise assessment of patients with possible ALI. That came out of the report that there was huge inconsistencies in the way these patients were assessed. So if we produce a standardised template to guide that, that would seem a pretty straightforward thing to do. Suggestions 2 and 3 are all about reducing delays. There's delays at several sites in the pathway. There were delays associated with diagnosis, and what we should do is trying to improve diagnostic accuracy. Quite often the history, this again comes out in the report, we classically think of acute limb ischemia as presenting with the 6 Ps. It often doesn't, and we need to improve diagnostic accuracy, and maybe produce, like we've done with DVT, maybe a Wells type score based on the history examination, supplemented with creatinine kinase. There's some suggestion that a creatinine kinase can be used to predict for diagnosis and to predict outcome. The higher your creatinine kinase, often the worse the outcome. And then only this year, there's been publications in the literature about the use of thermography Everybody's got a smartphone. You can use infrared camera to take a picture of the foot and measure temperatures. So the second suggestion to reduce delays is risk stratify and transfer patients with acute limb ischemia in a timely fashion, especially Rutherford 2B. This would require universal adoption of the Rutherford classification, which currently isn't well done, but I think will raise awareness and educate clinicians about how to grade the severity of acute limb ischemia, because the severity guides management, and how we could risk stratify and ensure the appropriate patients are referred and transferred is to develop an acute limb ischemia toolkit. There's several people around this table who are experts in developing toolkits. I'm looking at Miss Bell. She's trying to not look at me, I think. There's experience in this around this room of developing a toolkits specifically for aortic dissection, and we should aim to do this for acute limb ischemia. This will help clarify the management pathway. Third thing we can do to reduce delays is to organise vascular networks, and particularly generate transfer guidelines. Highlight of the report was delays in getting patients transferred from spoke to hub. And again, the Vascular Society has been involved with the development of transfer guidelines for patients with ruptured aneurysms, which reduce delays and improved outcomes for patients. We work with the College of Emergency Medicine for that, and it's something that we could achieve pretty quickly. It's crucial to have multidisciplinary MDTs, and this might be an idea for GIRFT, but every trust has one or two patients who, because of acute limb ischemia and delays, have lost a leg, and they've successfully sued the trust for millions of pounds. So one of the outcomes would be to look at medical legal claims and medical legal outcomes as a outcome measure. What we also should do, this almost goes without saying, is strive to provide high quality evidence-based care. And the aims of that would be to maximise limb salvage in the acute phase. And we're lucky in that we've got a funded randomised controlled trial, which is about to start recruiting, which is going to compare open versus endovascular revascularization strategies. We should use this to develop national guidelines, which will guide interventions to reperfuse the limb. I think there's also a piece of work that needs to be done around palliative care. In patients with Rutherford 2B, who the most appropriate intervention is palliation, we need to provide that palliative care quickly and to a high quality. And we need to address whether palliative amputation is ever indicated, and in what particular situations it is indicated. And then finally, something that wasn't included in the report is what happens to the patient once their acute episode is over. These are frequently some of the most frail at-risk patients, and we don't know really, we haven't got great data on what their major adverse cardiovascular events are, major adverse limb events are, and mortality in the subsequent 12 months. So it's important that we consider which are the appropriate management of the underlying cause. And because patients with acute limb ischemia represent a spectrum of diseases, everything from atrial fibrillation to thrombosis and bypasses to thrombosis of endovascular stents to coagulopathic patients with metastatic carcinoma to thrombosed popliteal aneurysms, the subsequent management of these patients is likely to vary from patient to patient. So there's specific subgroups that we need to think about what's appropriate secondary prevention for these patients, what's appropriate intervention to treat their cause. When should their popliteal aneurysm be treated? When should their aortic aneurysm be treated if they've had an embolus from an aortic aneurysm, for example? And then what's the appropriate medical management for these different groups of patients? Who should just be on an antiplatelet? Who should be on an anticoagulant? Should that anticoagulant be prophylactic or therapeutic? And we're doing a similar trial in patients with CLTI who've had endovascular treatment, the Clarity trial. It's not too much of a leap of faith to think that this could also be done in patients after an episode of acute limb ischemia. The evidence in the literature, as highlighted in the European guidelines, is pretty awful to guide management. To expand on what Rachel said, what we also need accurate, complete, focused data capture, and this should be a national acute limb ischemia registry. And there, as I see it, there are three options. There's the NVR, but the NVR is a fantastic database and has provided fantastic information over the past 10, 15 years. But there are problems with it. It's an interventional database, and so would need amending to capture data on patients we treated with simple anticoagulation or patients we treated with palliation. And there are funding concerns. The NVR has only got guaranteed funding for another 2 years, and there are many national registries that have had their funding withdrawn. NCEP, there's some concerns about accuracy of the data due to coding restrictions and coding problems, and there's also concerns about ascertainment. And the final option that we should consider is a standalone registry. That there are some excellent standalone registries. The National Joint Registry, for example, is an excellent one, but that comes with its own challenges, namely funding. The National Joint Registry is funded by industry, essentially. For every joint that goes in, a part of the payment for that joint is skimmed off and goes into funding the National Joint Registry. We also should think about, we are developing, as part of the established trial, a database on intervention for acute low limb ischemia. It wouldn't take too much thought to expand that. So the established database became a randomized controlled trial nested in a cohort registry. And that would be hugely valuable and would avoid doubling effort, if you like. So significant work to do. We need to think about what is the best way forward to do that. And I would think what we need to do is develop a national multidisciplinary acute limb ischemia working group. I have floated this as an idea at VS Council, but I think this is a big ticket item. We need to get onto this as quickly as possible. We have talked about arranging a face-to-face summer meeting, perhaps in collaboration with GIRFT, but there's no reason why, if that's the way we want to go, we can't undertake preliminary virtual planning meetings. That will require some funding, and we need to think about where that funding will come from, whether it's from the VS, whether it's from all stakeholders, or whether we approach industry to fund that. I think it's crucial we, at this stage, identify and involve all relevant stakeholders, and the report does a brilliant job of highlighting which stakeholders need to be involved when. And I think it would seem sensible, as it's such a big piece of work that needs to be done, within that multidisciplinary working group, to have subgroups, each with a specific area of focus. Maybe a subgroup on education who will focus on educating patients and healthcare professionals. Maybe a subgroup addressing service provision challenges. Those areas I've already highlighted about improving the accuracy of diagnosis, developing a toolkit, developing a management pathway, pushing forward with a registry. And then finally, it was fantastic to see at the end of an NCEPOD report, recommendations for further research. We are currently, addressing some of these research questions, but like any excellent report, it raises more questions, and these need to be addressed in an appropriate fashion with the right people, the right methodology, and the right support. And it would seem that a research subgroup would be best placed to address this. Thank you.